I'm going to break down everything you need to know about platelet-rich plasma injections for knee arthritis, backed by the most up-to-date clinical trial evidence and research. Hey everyone, Dr. Jeff Pang here. I've co-authored research papers, written blog articles for the British Journal of Sports Medicine, and created numerous educational resources on platelet-rich plasma. But despite the growing evidence, misinformation still persists. Some orthopedists still dismiss PRP, while others in regenerative medicine are making exaggerated claims about its effects. That's why I'm going to go over everything we currently know about PRP. We'll cover platelet dosing, PRP formulations, outcomes data, and how PRP impacts arthritis progression. By the end, you'll have a clear and up-to-date understanding of everything we know about PRP injections for knee arthritis and cartilage injuries. So let's first start with what is platelet-rich plasma. PRP is an innovative treatment that involves the use of a patient's own cells to promote healing and induce recovery in various areas of the body. We first draw your blood, put it in a special tube, centrifuge it. Your blood separates into layers, and we take the layer that has all your platelets and growth factors and inject that into your knee. The goal is to use your own cells to decrease pain, decrease inflammation, lubricate the knee, and protect your cartilage. The big question has always been, does PRP actually work? In previous years, there was always some uncertainty about its effectiveness, as some clinical trials showed positive results while others did not. However, in the last 2 to 3 years, this uncertainty has faded. The most recent clinical trials have consistently shown that platelet-rich plasma injections are highly effective for treating symptomatic knee osteoarthritis, making it arguably one of the best treatment options available for knee arthritis. Orthopedic, medical, and surgical societies now have consensus statements and summary overviews confirming that PRP injections are highly effective for the treatment of knee arthritis. For example, the American Academy of Orthopedic Surgery Technology Overview paper writes that PRP injections have been shown to outperform placebo injections, hyaluronic acid injections, corticosteroid injections, exercise and physical therapy, and oral medications. The position statement put out by the American Medical Society for Sports Medicine writes that PRP injections are more effective in reducing pain and improving function than steroid or hyaluronic acid injections for knee osteoarthritis, particularly in those who are younger and have mild to moderate disease. European societies, such as the European Alliance of Associations of Rheumatology, have also established clinical practice recommendations for PRP injections. They write that Number 1, PRP injections are an efficient treatment of early or moderate symptomatic knee osteoarthritis. Number 2, PRP injections may be useful in severe knee osteoarthritis. And number 3, PRP injections in knee osteoarthritis should be proposed as a second-line therapy after failure of non-pharmacological treatment like exercise or physical therapy and pharmacological therapy like oral or topical anti-inflammatory medications. Okay, now that we've established that PRP injections work for knee arthritis, I now want to point out something critical. Not all PRP is the same. It turns out that the dose of PRP really matters. Just like with any medication that we use for blood pressure or diabetes, there is a dose-response curve, and we now have a pretty good idea of the dose-response curve of PRP. The reason clinical trials from over 5 years ago did not show positive results with PRP is because the vast majority of them used low-dose injections. This review found that studies in which PRP did not result in a good outcome in knee arthritis had a mean platelet dose of around 2 billion platelets. Studies that showed PRP worked extremely well had a mean platelet dose of around 5.5 billion platelets. Further systematic reviews and meta-analyses find that even higher doses, reaching 10 billion platelets, result in the most favorable clinical outcomes. So how can you tell if you're receiving a high-dose PRP injection? The key is to ask your provider how much blood is being drawn. The more blood that's being drawn, the higher the platelet dose. I recommend aiming for 10 billion platelets per knee arthritis injection, which typically requires a 60 cc blood draw. This is the most important question to ask when getting a PRP injection. Many doctors performing PRP injections are still not yet aware of the importance of platelet dosing. The next thing you want to do is ask about how the PRP is processed. There are many centrifugation protocols protocols, each with its advantages and disadvantages. Single spin techniques are faster and more time efficient, but it generally recovers fewer platelets. Double spin centrifugation takes longer but recovers significantly more platelets, leading to a higher dose. So the two key things to confirm with your healthcare provider are, number one, are you getting a 60 cc blood draw? And number two, is a double spin centrifugation protocol being used for preparation. Once you're certain you're getting a high dose PRP injection, the next question you want to ask is, how many treatments do you need? This is where the research is still a little unclear. However, the current consensus is that 3 injections are better than 1. A previous randomized control trial supports this, showing that patients who received 3 PRP injections had significantly better outcomes than those who received just 1. The caveat here is that each injection in that study delivered around 5 billion platelets. Remember, the goal is to aim for 10 billion platelets per knee arthritis injection. Many recent studies show that a single high-dose injection of over 10 billion platelets can produce excellent results, lasting up to 1 year in patients with mild to moderate osteoarthritis. The big unanswered question is, how much better are the outcomes of 3 high-dose injections compared to just 1 high-dose injection? While we're uncertain about the impact on pain and symptoms, it is likely that 3 high-dose injections are more effective for modifying the progression of arthritis. This study compared 3 high-dose PRP injections spaced 1 week apart to placebo injections. The results showed that PRP significantly outperformed placebo in both pain relief and improved function. More importantly, after 5 years, the PRP group experienced nearly 50% less progression of arthritis as measured by cartilage volume on MRI scans. This is the strongest argument for opting for multiple injections, as we currently have no other disease-modifying treatments besides exercise, nutrition, and weight management that can slow down the progression of arthritis. While a single high-dose PRP injection can address pain and symptoms, it may not be as effective at slowing the progression of arthritis compared to a 3-shot series. Even more exciting is that there are now studies that suggest multiple PRP injections not only slow the progression of arthritis, but could also help rebuild some cartilage. In one study, patients received 3 PRP injections at 1-month intervals, and cartilage thickness was assessed at 6 months. The results showed an improvement in knee cartilage thickness as measured by ultrasound from 0.92 at baseline to 1.01 at 6 months. Another case study highlights the effects of PRP in treating a high-grade cartilage injury from osteochondritis dissecans. At baseline, an MRI measured the cartilage defect at 2.2 by 1.4 centimeters. The patient received 4 ultra-high-dose PRP injections, each involving a 180 cc blood draw. 3 years later, a follow-up MRI revealed that the defect had reduced to 0.7 by 0.5 centimeters. This is the first case to demonstrate the healing of a large cartilage defect in the knee after repeated PRP injections. Now, these findings on cartilage regeneration should be viewed with caution, as they do need to be replicated in much larger clinical trials. However, the potential for cartilage restoration and healing is exciting and highlights the promising benefits PRP may offer. While PRP won't bring back your youthful knees, it could slow the progression of arthritis and even promote some healing, something that can't be said for any other injection treatment option currently available. The last topic that I want to quickly address is stem cell treatments. I get asked about this frequently, and it's an area filled with misinformation. In the United States, there are currently 3 types of stem cell injections available. I use quotes because recent research suggests that these products contain little to no actual stem cells. This report analyzed 7 commercial companies that provide amniotic fluid stem cell treatments. They write that mesenchymal stem cells could not be identified in the commercial amniotic fluid products or the unprocessed amniotic fluid. Nucleated cells were found in only 2 products, but most of these cells were dead. They conclude that amniotic fluid products should not be considered stem cell therapies, and researchers should use caution when evaluating commercial claims that products contain stem cells. This is why most regenerative medicine doctors use either bone marrow aspirate concentrate, BMAC, or adipose-derived stromal vascular fraction, or SVF. However, a new study now raises questions about how many live stem cells are actually present in these treatments. In their analysis, BMAC stem cells made up only 0.22% of the total cells, while SVF stem cells accounted for just 1.11%. So, should these treatments even be considered stem cell injections if they contain so few live stem cells? And what does the outcome data say to justify their use? Surprisingly, the largest clinical trial on these therapies found that they don't even outperform corticosteroid injections. This was the largest stem cell trial involving 440 patients who received either BMAC, SVF, umbilical cord product, or a corticosteroid injection. The results after 12 months showed that none of these three stem cell treatments outperformed each other, nor did they perform better than the corticosteroid injection. Additionally, MRI scans revealed no significant changes in cartilage or arthritis scores with any of the stem cell treatments compared to baseline. Based on these results, it's hard to justify recommending stem cell treatments over platelet-rich plasma injections at this time. This is especially striking considering that stem cell injections can cost $5,000 to $10,000 per treatment, while PRP typically costs around $700 to $1,000 per injection. For the price of one stem cell treatment, you could get 5 to 10 PRP injections, making PRP the far better option in terms of both price and efficacy. I really hope this information about PRP injections for knee arthritis has been helpful. However, it's also important to note that not all doctors who administer PRP are the same. There are several factors to consider when choosing a PRP specialist. In the next video, I'll cover what to look for when selecting the right healthcare provider to administer your PRP treatment. Thanks for watching.